Good evening, everyone. Welcome to the 123rd Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And today's virtual seminar is a pre-conference webinar by Ethiopian Society of Anesthesiologists and Professional Association, which is brought to you in collaboration with Blue Hills Ethiopia. Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Heno Tadela from Blue Hills Ethiopia. Today, it's a pleasure to have Dr. Dr. Ananya Abata Shifero here with us to have a presentation on anesthesiologists as champions of national and global health, expanding the role beyond the operating room. Dr. Ananya is a consultant anesthesiologist and pain subspecialist. Is also the director of anesthesiology program at the University of Botswana. So I will be giving the stage to Dr. Yasu from Ethiopian Society of Anesthesiologists Professional Association to introduce Dr. Ananya. Yasu, the stage is all yours.
Okay, thank you. I would like to welcome our speaker, Dr. Ananya, and everyone. So, as it is as the introduction has already been done, I will not be repeating the process. I will leave the floor for Dr. Ananya to proceed.
Okay, thank you very much. Thank you, Dr. Yasude. Thank you, Dr. Heno, for a nice introduction. I'm glad that I'm invited to speak on this topic, which is current and very important. So it's about anesthesiologists being champions for national and global health. So the role of anesthesiologists is beyond the operating room. So that's what the topic states. So I will try to as brief as possible. Let me check if I'm audible or not. Am I audible?
Yes, so
Okay. So I don't have anything to declare. Objective of my session would be to discuss on three most important things from this topic. First, I will try to explore the evolving role of anesthesiologists beyond the OR. Then I'll show or highlight contributions to health system policy and global health. And I will take the opportunity to inspire for advocacy and leadership in broader health arenas for anesthesiologists. So let me start by giving you certain facts about anesthesia. As you all know, anesthesia was labeled as an invisible sister of the neglected stepchild of global health. This was a publication from the Lancet Commission on Global Surgery 2025. So to understand this statement, I want you to look at the picture here. So definitely you can see that there is a stepchild who's unhappy and ignored. So that stepchild is a surgery. Okay, if you take this whole picture as a global health or a health system in any country, then you can differentiate who is a child and who is a stepchild. And the stepchild is always unhappy and ignored. So that stepchild is a surgery. So in the picture, can you try to take a few seconds to find where anesthesia would be placed? Which individual represents anesthesia in this picture? So for sure the answer is no one is representing anesthesia in the picture. The anesthesia is now invisible. So the anesthesia is the invisible sister of the neglected stepchild of global health. So this is basically manifests, or a reason behind this could be shortage of trained personnel, but also inadequate resources and limited training opportunity manifests as invisible being invisible in the global health system. So that's when anesthesiologists has to come out of the OR and do some advocacy and become successful in May 22, 2025 in passing a groundbreaking resolution on the 68th World Health Assembly, strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. So with this resolution, at least now, the world has accepted anesthesia is and surgery is a part of universal health coverage. So by 2030, the world has planned to achieve a goal of universal health coverage for all. This is part of sustainable development goal. So it all now depends on having functioning surgical system. So this is a great opportunity for us now to advocate and lead through anesthesia in order to achieve functioning surgical system in 2030. So the ground baseline work was done some 10 or 15, 20 years ago. So anesthesiologists there come out to advocate and be successful in having a resolution on the 68th World Health Assembly. So some of the figures they used for this resolution was, at that time, based on evidence study, 5 billion people out of 7 billion people do not have access to safe and affordable surgical and anesthesia care. And when you see the attention at that time by the health community, Ministry of Health and government and the politicians were on TB, HIV, and malaria, which was supposed to be killing more people in low and middle income countries. But studies have shown that deaths from treatable surgical diseases is 4 times higher than TB, HIV, and malaria combined. So we were able to show the world that managing surgical disease is also as important or even more important than managing TB, HIV, and malaria altogether. And in low mid and middle income countries, particularly, we are faced with low number of trained anesthesia providers, which is like 100 times fewer than the higher income country profile. Not only that, mortality because of this in low middle income countries is like 1,000 times. So emphasis has to be given for anesthesia and surgery so that we can avoid this mortality and we can provide safe and affordable surgical and anesthesia care for 5 billion people out there. So if we have these resolutions like 10 years ago, why this topic now? So yeah, Ethiopia is one of the low and middle income countries. We believe that the advocacy and attention given to anesthesia is still lagging behind as compared to other high income countries or even other low and middle income countries. But there is an opportunity. So there is growing recognition of anesthesia in global health discourse. And because of the efforts by WHO and World Federation and Society of Anesthesiologists, now safe anesthesia is given a public health priority. And there is also a focus on health system strengthening and universal health coverage. So as part of the Sustainable Development Goal by 2030, every country is expected to achieve universal health coverage. And successfully, our 4 leaders in anesthesiology has made it possible that surgery and anesthesia is part of the universal health coverage. So we have this opportunity to work on That's why this topic is pertinent at this time. So if I say so, then let's go with what was the traditional role of anesthesiologists. So previously, if this was a talk given like 20, 30 years ago, this was a picture everyone is looking when we think of anesthesia. So an old guy depressed just by the side of the anesthesia machine, holding bag, and probably a better picture would be someone sitting in the OR reading magazines or looking into phone would be the representation of anesthesia. But that's not right, right? So anesthesiologists start to advocate that okay, anesthesia is beyond what is done in the operating theater. It is a perioperative care. So when we say perioperative care, starts with pre-op patient evaluation and creating rapport in pre-anesthesia clinic, then managing patients pre as well as intra and post-operatively, not only from the anesthesia point of view, but also medically managing, optimizing them under the multidisciplinary team. And post-operatively, it involves also visiting patients, going to their ward, and creating a communication. So we were struggling to convince people that, okay, anesthesia is a perioperative care. But today we are not. So our today's main topic will not be, okay, anesthesia is perioperative care. We still consider this as integral part of anesthesia. And this is one of the clinical work of anesthesiology. But we want to see beyond that. The other is pain management. Yeah, it's not only acute pain management, but anesthesiologists are tailored to do also chronic pain management in clinics. Because they are doing chronic pain management in clinics, it doesn't mean that anesthesiologists just went out of the operating theater. So the definition of anesthesiologist going outside theater is something more than just a clinical practice. Even it's not just a critical care, or it's not just resuscitation and emergency response, such as we are seeing in med evacuation, in ambulance, air ambulance. Okay, even anesthesiologists nowadays are practicing in palliative care. Okay, having centers. So these all may not be considered in the current understanding as beyond the OR. Okay, this is within the scope of anesthesiology. But what do we mean by beyond the OR? Now we need to stress on creating awareness in the public, creating awareness in the health system, and being influential nationally and globally, and making sure that anesthesia remain safe and we are providing quality anesthesia care. So to show you a few examples or research outputs, for example, 60% of US citizens or population recognize anesthesia as a nursing discipline. So that really shows you how the awareness is really lacking. So this demoralizing for anesthesiologists as well. That could be one of the reasons why anesthesiologists stay in the OR, or vice versa, because anesthesiologists are only staying in the OR. They are shy, they are dormant, so they are not being recognized by the public. And one of the study, this was what I did for my thesis in Ethiopia in 2014. So only 2% of medical students know what the role of anesthesiologist is. So you can imagine what it would be for the population by itself. So with this lack of awareness, recognition, then anesthesiologists will not be achieving what they want. So we have to acknowledge that our role is evolving into a health system. So to achieve this, it needs individual effort, it needs collective effort as well. So when we say collective effort, it could be group of people in the same hospital, It could be Anesthesiologists Association as Ethiopian Society of Anesthesiologists, or regional association, or global associations in society and advocacy group. So by participating or involving in such groups, we have to bring a change in anesthesia in terms of quality, safety, and whatever. So involvement in public health policy is important. Example could be surgical system strengthening. You know that now most low and middle income countries have now national surgical obstetric anesthesia plan. So when this plan is developed, we as a group or individually should be part of it. Without us, this kind of program or planning or strategy should not be done. So now this defines that, okay, we have gone out of the operating theater and we are doing something for a public health policy. Otherwise, if we are sitting in the operating theater or in an ICU, paying clinic, if we are only doing clinical work, then we cannot influence on the public health policy. And those people who are making those policy also would not know what the anesthesia care could look like. So rather than sitting and waiting them to call us, we ourselves has to be the initiator and go there to discuss with them. The other thing is health workforce training. Okay, education in Ethiopia seems to be hand in hand with our clinical activity, but education needs further training, further research on that area. So we need to be upgrading ourselves in medical education, simulation, and curriculum development so that we can train very we can train appropriate anesthesia provider for the country. Leadership is also the other dimension we should be looking into. Leadership could be simply being a coordinator of a unit or OR, ICU, or it could be directing, it could be becoming a hospital administrator like CEO, or it could be working in an NGO association like Ethiopian Society of Association. We could be a president there, secretary, and so on. This all is a leadership. But this also needs some form of practice training. Because it needs some part of practice training, so many anesthesiologists are afraid of doing such activities. So it seems there is a lack of also going for that position. So I think now is the time. The situation also pushes everyone to be a leader. So this is one of the evolving role. Okay. The other thing is we are anesthesiologists are very much now for advocating safety and also doing the safety measures and quality improvements projects. So anesthesiologists most often nowadays should be involving in issues related to patient safety and quality of care wherever they are working. It could be a remote hospital, it could be a major teaching hospital, but we have to come out of OR and also do such things as patient safety and quality of care. So definitely we are first liners in humanitarian work and crisis response. So whenever there is a crisis, we have to take forefront first and to go there and support. And the research is one of the areas there. It's highly related with our clinical activity. But if you are not giving it time, and if you are not able to acquire skill in doing research, then you'll still remain inside the operating theater. So you have to come out of the traditional thinking and you have to start doing research, generate data. Your management has to be evidence-based medicine. Then innovation, technology, manufacturing industries, all are places where anesthesiologists can go and fit and do contribute. So to make it clear what I'm trying to say, to make it clear, let's see some few examples. One of the best example would be the experience from Rwanda. So let's say in Rwanda, like in 2000s, early 2000s, there were only handful of anesthesiologists, maybe five, six, seven. Then there was a huge surgical backlog, and the anesthesia delivery was seriously unsafe. So these few anesthesiologists, they have the chance to sit and do whatever is clinically required of them, but they sat down, think over it, and they realize that sitting in the operating theater and only doing their clinical function will not be having a great outcome for Rwanda population or the healthcare system in Rwanda. So they have to partner with the Ministry of Health and call for international collaborators so that they can bring a lot of change. So they did two major things. One, they develop a national training program for non-physician anesthesia providers. So when they do that, they were supported by ministries, they were supported by international collaborators, surgeons. So they mobilize everyone, and they kind of take a leadership on this process. And when they do that, they determine the scope of practice for non-physician anesthetists. They have a guideline and clear supervision guideline and how to work with physician anesthetists as well. So by developing this, they kind of make anesthesia delivery a bit safer, and they make emergency surgery and anesthesia care accessible to the people of Rwanda. At the same time, also they did something even higher, the National Surgical Obstetric Anesthesia Planning Strategy. So they make a part of people who made this plan for Rwanda, which was among the first in Africa at that time. So combining these two, now they can influence the conduct of anesthesia in Rwanda, because within this document, now they dictated the human resource need, they dictated the equipment need, which ones are essential, which ones are non-essential, and they have produced different guidelines and protocols which guide how anesthesia is given safely. Okay, so they will be heard at the hospital level, hospital administration, at ministry of level, at the government level. So today, now Rwanda has increased anesthesia providers and perioperative safety is improved. But this has happened because the anesthesiologists gave time to focus on developing something at the higher level, at the ministry and public health level. So there are champions there, individuals and groups of anesthesiologists were championed to cascade what was there in 2000 to now, where there is an improvement in perioperative care. Ethiopia, yes, in Ethiopia also we have seen a great improvement. Like early in 2000s, maybe the number of physician anesthetists could be less than 20. We were heavily relying on non-physician anesthetists, and there were limited access to safe anesthesia, especially if you go outside the major cities, because most physician anesthesiologists were on major cities, basically Addis Ababa. So individuals and also teamwork has created a lot of improvement in the past 2 decades or 25 years. So one of the outstanding job which really created a base for improvement was inclusion of like one anesthesiologist for a general hospital in a standard. So when a standard was made, so at that time, anesthesiologists were able to attend and was heard on that instant, and at least one anesthesiologist for a general hospital is approved. That really created the way the system sees anesthesiology. So Ministry of Health, based on that, was forced to hire or to sponsor residents immediately after finishing their medical education. So if that standard was not changed, it would be very difficult for decision makers at the ministry or at government level to decide, okay, physician can join anesthesiology training program immediately, because the rule was at least someone has to serve a couple of years in a remote area before joining a residency program. And that was a hindrance to increase the number of anesthesiologists in the country. So because at that time anesthesiologists, okay, they preferred, okay, we have to fight this thing, we have to save time from our clinical activity and go ahead in at the ministry level or whoever is doing the standard and influence people there, and included one anesthesiologist for a general hospital suggestion. Then in anesthesia roadmap development, national surgical obstetric and anesthesia plan, two parts it has got. It's a safe surgery saves life, part one and part two. We were involved, anesthesiologists, as a team or individually, we were involved, and that really helped for the progress we are seeing now, including developing national anesthesiology curriculum among few specialties who develop national anesthesiology curriculum. Anesthesiology stands out also as the first, and we had a very good contribution in national residency matching program and to the level of doing also national perioperative guideline. Okay, previously, if someone says perioperative guideline, usually the surgeons have to be contacted, but nowadays perioperative guideline, when you see people in the ministry or elsewhere, they usually seek assistance from anesthesiology. So the name anesthesiology and our role and our capacity is now well better, even though I will not say well, it's better recognized than what was before. That's the reason why also the number of anesthesiologists is increasing in the country. So this is a quotation, okay? So many individuals may use it. I have used it before as well. So I will read it for you. So we realized that if we stayed only in the OR, nothing would change. We had to be part of the system redesign. So this quotation just summarizes what I have said before. So if you are sitting just doing only clinical job, nothing will change. So we have to go there to change the system. So just let me give you, or as an inspiration, there are few anesthesiologists in my slide, but many anesthesiologists have done a lot of job nationally or internationally or within their hospital to improve the awareness of the population and also to improve the anesthesia care in general or the health system in general. So one of whom is Dr. Angela. She's from Canada. She was the first female president of the Canadian Anesthesiologists Society. She was also WFSA president in 2008. So she has done a lot of work. But one of the most important is a global pulse oximetry project. So previously, anesthesiologists were not using pulse ox, especially in low middle income country. It was not accessible. But she facilitated this project for the formation of also life box, whereby pulse oximetry can be delivered for free in a low and middle income country. That really changed the service, that really make anesthesia safe. So this lady, she just didn't sit and do her clinical activity only. She wanted to go beyond and have a global impact. Also, she was known for developing educational and training materials and assisting anesthesiology training in low middle income countries, especially focuses in East Africa, Rwanda. So, yeah, this Dr. Angela is one of the inspirational anesthesiologists here. The other one is Dr. Janike. Unfortunately, she passed away a few months ago, suddenly in Norway, but she was a very known, famous anesthesiologist, also WFSA president in 2018 to 2020. She's well known about her humanitarian activity, and also she was the first lady to provide military health service in Norway. She was very much known by driving force behind the Helsinki Declaration on Patient Safety in Anesthesiology, which was launched in 2010. So we say anesthesiologists are at forefront for patient safety, and one of the testimony is Dr. Janike, where she organized European anesthesiologists and sit down on Helsinki to declare patient safety in anesthesiology. So this material now is a reference for everyone to be used worldwide to ensure patient safety in anesthesia. I'm sure most of you also know Dr. Virginia Abgar. She was born in USA. She's US by citizen. She was there as a doctor before World War II, and initially her plan was to be a surgeon, but that time females joining surgery was not that easy. So her mentor advocated her. Her mentor actually pushed her against her wish to join anesthesia, as anesthesia was evolving at that time because of a lot of anesthesia related complication. But after joining anesthesia, she really liked it. She did fellowship in obstetric anesthesiology. She became a professor. But she was not only doing clinical activities. She does a lot of researches. She used to educate, whether it is anesthesia related or even non-anesthesia topic for medical students. And she was advocate for anesthesia, so she wanted to establish anesthesia education in her hospital. She was also innovator. What's really inspiring today is about how she developed Apgar score. So the Apgar score is not something which is used by anesthesia only, but everyone obstetrician, pediatrician, or any physician will use today. Apgar score is named after her. She developed a tool, this tool, in order to assess neonates after delivery. So this kind of innovation is expected from every one of us as anesthesiologists. So the same thing, Dr. Bonica, John Bonica is USA, is the father of modern pain medicine. Initially around World War, he was alone managing pain of the military who suffered a war injury. So he see how significant pain affects some life. So initially started by himself, but later he understands that pain management cannot be just done by one individual only. He needed a multidisciplinary team like psychiatry and so on. Be a leader, organize the team, and created concept of multidisciplinary pain management and chronic pain management. And to help advocate this worldwide, he established the International Association for the Study of Pain. So this is one example how you can start clinically, but from what you see clinically, you broaden it to be out of the OR activity as well. So will we have challenges in order to be successful in this regard? Yes, anesthesiologists are under-recognized worldwide, and it's worse in low and middle income country. But we have to work hard in this line. You can't just sit down because you are under recognized, but rather you take a step forward and work on it. There is workforce shortage. We are too few, but still you can learn from Rwanda. They were very much short in number, but they have to choose the battle. Okay, are they going to sit down and do clinical job only, consume all their time, or some of them should go to publicans and advocates and uh, take part in policy making? So there is limited funding for non-clinical roles, so we have to work hard on that line. There is issue of burnout and workload. So people may raise, okay, I'm doing clinical as well as I'm going to the ministry, I'm going to policymakers, I'm having a meeting and so on. How am I going to manage? Yes, manage time. This is a challenge, but we have to come out of the challenge. So we have to select, okay, if I'm going to spend more time in clinicals, then let me cut that and be in the policy making side. So it's challenging, but always there are opportunities. So you have national regional collaborations there. Leadership trainings are now available. Medical education simulation is available. Research collaboration is well open. Technology is advancing, really is supporting for innovation and public health and policy making. Then there are several health advocacy groups in society you can join and you can bring an influence or a change in your system. So I would like to call for action at this venture. So try to be visible. Like being visible starts with what you are doing in your clinical activity. So in your clinical activity, be visible. Don't be the silent, calm, depressed person, which previously was given to anesthesia. Then be a leader also. So it takes time to be a leader, but practice each day. And try to embrace your role as a system thinker. So let's say now, what do we mean by that? Let's say now you are providing anesthesia in one of remote hospital. So do you have a pre-anesthesia clinic, for example? If you don't have, then now you have to think of having a pre-anesthesia clinic. Or do you do a post-op visits? No, then you have to think of doing a post-op visits. Do you have morning session? No, then think of going to the surgical morning session and try to be visible and also show your concerns and make change at your hospital level. Engage with policymakers. Don't wait policymakers to call you. Rather, you go ahead to policymakers and discuss. And when you develop this skill, please mentor also next generation. This has to pass to the next generation as well. And don't hesitate to join national global health networks and advocacy. Because these things are intrinsic to anesthesiologists. So we as anesthesiologists are critical thinker, system leader, and crisis manager. This is happening because of the nature of the anesthesia by itself. When you are managing intraoperatively, you manage crisis. You try to lead the system because you have to communicate. There is nothing you are going to do alone. You are doing things as a team. So that team needs to be led. You are the one who's having a nice hands and free to manage as a physician intraoperatively because the surgeon is already occupied on doing the surgery. So you are also expected to be a critical thinker to make a decision. So because of that, knowingly or unknowingly, you have that potential to be leading, to be beyond the OR and ICU. So be in a national policy panel, be in a policymakers meeting, be in a high political meeting. Go there and show what you wanted to achieve. So whatever you have clinically is transferable to a non-clinical job you are expected to do. So anesthesiologists don't just respond to crisis, but we anticipate and design systems that saves lives. So that's why we have plan A, plan B, plan C. So we shouldn't sit down and wait for others to design system for us. So the health system should be designed the way we want it as well. So we have to be part of that system design. So I want to remind you about Dr. Abgar now. She should be a good example here. Long before global surgery became movement, she changed the world, right? So this movement was in 2010, 15, and after 2000. But she died in 1975, I guess. So a long time ago, she was able to penetrate the global health and influence the global health by just asking, how do we know if a baby is okay after birth? And that question has led her to come up with a global tool, and that tool is now well accepted and still being used. So such innovation, such dedication, and such thinking out of the box is important in order to go beyond OR. So anesthesiologists have long been quite heroes of patient safety, and this has changed a lot currently, but still continue to be the case in most low middle income countries and also in our country as well. So the world needs more than silence. So we need to be leaders. So we have to step forward, speak up, and lead because we are standing at the intersection of critical care, surgery, public health, and education. So that really makes us uniquely qualified to drive health system change, be it locally, nationally, and globally. So when I say be a leader, leadership is not about position. So most our anesthesiologists at this time may have some leadership roles. Okay, beyond the being a department lead, they may be ICU coordinator or coordinator, could be academic director. They may have a role in the regional health bureau and so on. But it's not about only position. It's about how you can create influence. So every anesthesiologist has a chance to influence. So we need to influence the health system the way we want it. And anesthesia has to be safe, and anesthesia has to be affordable, and anesthesia has to be delivered to the population who needs it. So, in summary, anesthesiologists have critical roles beyond the OR, so we all agree that. And the national and global health needs your leadership, anesthesiologists' leadership, because anesthesiologists have a unique character of intersection in critical care, surgery, education, simulation. And the anesthesia by itself made them, through a clinical practice, made them to be a leader in critical care. So let's step up as champions for health quality wherever we are working, so that we can see the change we want to see. Yeah, thank you very much. So this is my email address and WhatsApp number. Anyone who wanted to contact me, or I don't know, provide comments, you can use my contact. But I'm ready to answer your question or comment. Thank you, Dr. Yasu.
Okay, thank you very much, Dr. Yasu, as well as Dr. Idarsal. There's a comment for you, Dr. The chat box. So, participants. If you have any questions and or comments, you can write it down in the chat box. Okay, there's one question from Yasu. It says, do you have any specific areas you recommend to work on in Ethiopia?
Okay, I think it's a very nice question, but the way I want to respond to this question is I want everyone to think about that specific area he or she or in total, in collaboratively, you guys want to work on. So there are a lot of areas to work in Ethiopia. Anesthesia is never explored. So be it innovation or improving what we are doing. So how are we in opening pre-anesthesia clinic and making the pre-anesthesia clinic run well? How are we in research? How are we in quality improvement projects? How are we generating data as a country nationally? Do we have a registry in terms of anesthesia if we want to change the system? Pain management is almost neglected. So how are we doing the acute pain management? Do we have a 24 hours acute pain service? What about highly neglected chronic pain? Are we providing that? Are we opening pain clinics in different institutions we are working? So there is a lot lacking there. And also, how are we dealing with a health policy? So we have a perioperative guideline, for example. We have a national surgical obstetric anesthesia plan. So is it going the right way as it was planned? Are we checking it? So do we have even those documents at our hand, everyone in Ethiopia? So these are the things to do. So this is a question to be asked for everyone. So each one of you in Ethiopia has to think about, okay, what can I do best, or what can I do other than just my clinical activity to bring about a change in my practice area or in the field. Yeah, so it's not limited. That means it's not limited. It should not be specific thing to be done now, but you can start whatever you like as far as it's as a consequence in improving the safety of anesthesia practice.
All right, thank you. One comment by Idarsal is, it will be very good if we can have other clinical webinars by grand seniors like Dr. Ananya. The way he teaches us is extraordinary. That's well noted, and we thank Dr. Ananya for taking the time to present on webinar, and we hope we will have him in future sessions with related and other topics as well. So there is another question by Ibrahim. Thank you for the presentation. As mentioned, there is a shortage for anesthesiology professionals. As a short-term plan, what do you suggest?
Okay, it's a very important question. Yes, there is a shortage, but always we have to think when we are producing anesthesiology professionals, it should not be also compromising quality. So we have seen that now in physician education. So some few years ago, the number of medical doctors were very small as compared to the number of population. Now we know that Ethiopia has increased the medical doctors number significantly. It is below the WHO recommendation of physician to population ratio, but the economic capacity of the country couldn't handle and even hire those physicians to practice in Ethiopia. So when we think of managing shortage, then we have to think of the whole picture. It's not only seeing one picture, okay, number of anesthesiologists to population, but whoever were producing, then where are they going to be functioning? So in Ethiopia now, probably we have some nearly 400 anesthesiologists. If you make it 1,000 anesthesiologists now, will there be places or hospitals for them to practice? So that should be taken into consideration as well. But with the works we did in the previous years, now we have quite good number of anesthesiology programs, around 8. Probably we need to add some more, 3, 4, 5 programs. Then this program has to gradually increase the number of enrollments while maintaining quality. This is how we manage a shortage of anesthesiology professionals. And of course, anesthesiology by its nature, because it's highly demanding, in countries like Ethiopia, where there is a huge number of population, you may not be able to manage the anesthesia with physician anesthesiologists only. So you have to strengthen the same way also a non-physician anesthesia program. And you need to synchronize the two programs together so that they can function well and go along together. So in order to do that, as I told you, it's not only just, we cannot just sit only in the operating theater or in our clinical orgs, and we have to go to policy making. We have to take that leadership and work on that. But at current states, adding both physician and non-physician anesthesia providers, even though in terms of number, the anesthesia provider is short than what is recommended by WHO, but in practice, to the number of hospitals and to the number of, service we can give, those professionals may not be significantly short. Because we are seeing unemployment rate being increasing, at least for nurse anesthesia providers. And even last time, I was seeing there was a cap in hiring physician anesthesiologists. This is all related with economical issues and hospital facility, number of hospitals, or hospitals who's providing even surgical care. Surgical care is not just simple, it needs a lot of infrastructure there. So because of that, in Ethiopia, what I recommend is, okay, now the number of shortage in anesthesiology professional we are having is not that significant. Rather, we focus on quality, but continuous production of anesthesiologists and non-physician anesthesiologists is important. So just we need to expand our universities. We are providing specialty physician anesthesiology program and gradually strengthen them and increase enrollment. So I think I answered your question. If it's not satisfactory, then I will come back again.
Okay. Thank you very much, Doctor. There are a lot of positive comments in the chat box, and let me choose two last questions. So the first one is there any future plan from the society to change the system nationally, like roles of anesthesiologists to the Ministry of Health and the scope of practice as well?
Definitely, there will be a change from society point of view. I was a past president of the society, so there was some plan as the executive committee. I'm sure the current executive committee also would work on those plans which and works which was started before. And also, I know that we have a very good anesthesiologists in Ethiopia who are eager, and we wanted to change the system. So I'm sure there will be some plans going there, but I cannot tell you the details now what is going to happen because I would not be the right person to speak in terms of the activities relation with the Ethiopian Society of Anesthesiologists. But definitely there is activities are going on. It was activities were running. It shall also be going on.
All right. One last question is from Asfau Ahmed, and he says, brain drain is one of the major crises in Ethiopia, which has significant negative impact on anesthesia practice as well as involvement in leadership. What do you recommend on this?
Yeah, definitely that is true. But we need to provide that with evidence. It's a it seems like it's a well-known fact. Brain drain can affect anesthesia, not only anesthesia, the whole health system. It's currently a big problem in the country, but someone has to generate the evidence, right? So evidence in terms of research, output, and publication is important. And we need, as a society, we need to be heard and advocate that, okay, our anesthesia providers are leaving country, or our surgeons or our health care providers are leaving country because of this and these reasons. And that reason should be based on evidence. Okay, you can do a study, it could be a survey, but you can say, okay, I have these evidences as a brain drain, and the extent of brain drain is also this much, this significant. And uh, discuss with a responsible person or a responsible office and try to bring a change. Yeah, that should be one of the things we can do as a society. Yeah, that's what I can say.
Okay, thank you very much, Dr. Anani. So you have addressed all the questions raised, and as you can see in the chat box, there almost all of the comments we can say are all positive comments, and thank you again. So on behalf of Blue Hills Ethiopia and all our participants, as well as the Ethiopian Society of Anesthesiologists, this professional association, I would love to thank you for taking the time to present on the 123rd Blades virtual seminar as a pre-conference seminar. So we also would love to meet you in future sessions as well with other topics. I'm sure our audiences would also love that. So if you have anything that you want to add as a last remark, let me give you the chance one more time.
Uh, I have nothing to add, but I would like to thank for you to inviting me for this important topic. And also, I'm really happy to see most of my students, my colleagues here, also giving me a good comment. That really means a lot for me. And I'm happy to collaborate in any ways in the future. And we hope I hope anesthesia in Ethiopia will improve significantly. It won't be too far before achieving our goals. So I really appreciate for the good comments you have given me. Thank you very much.